Welcome everyone to VASEP Presents. Every July 1st, hundreds of new laws take effect across Virginia, but only a handful affect the House of Medicine and emergency medicine for that matter. So today, we brought in two guests, VASEP President Dr. Joanne Sequeira, as well as our Government Affairs Lead, Amy Perone-Seibert, to talk about some of the changes that are coming on July 1st and how they will impact practice. We want to know what changes during the shift, and we want to start with a non-compete bill that banned non-competes for healthcare workers in the state of Virginia. So, Amy, let's start with you. Tell us a little bit about this bill and how that impacts every emergency physician in Virginia.
Sure, happy to. This was a fight that we've been having for a couple years now here in Virginia, and we were able to be successful this year in ensuring that non-competes for physicians and other healthcare providers as well. But what we care about today is physicians will no longer be able to have non-competes in their employment contracts. So what that means is when you are working or negotiating your contracts, they can no longer say that you cannot that a non-compete cannot be included. So that means that you will be able to, if you leave your job, be able to stay and work in the community that you are in. Currently, that is something that has been a real bar to people's practice. If they non-compete was in their employment contract, they could have things that said they couldn't work within 30 miles or 60 miles of where they lived and worked. So if they left their job, they would have to move away. They couldn't stay. They couldn't keep their patients, and they couldn't keep caring for the people in their community. And so it's a big deal. We're
Yeah.
really excited about it, and it will take effect on July 1st.
And actually, surprisingly, a lot of academic sites still have non-competes or have not, when it comes to emergency physicians. I will say there's most community groups do not. But yeah, so there are a good number within the state of Virginia. So this is a big change for a lot of those academic sites.
Yeah, for sure. One of the ones that I think is going to make a big impact that I think a lot of physicians will welcome and a lot of patients as well is an update to the Cures Act, at least in Virginia. So, Dr. Sequeira, tell us a little bit about the new language to delay test results for certain exams.
Yeah, so just a little background. So the Cures Act is a federal law that took place a couple of years ago regarding immediate results being provided to our patients, right? And so we all know how much woe that has caused. And what we have found, though, that in cases of patients having malignancies, it's causing substantial mental distress, right? Receiving results that they don't understand. So we found out through ASEP that there were a couple of states that were delaying certain results in within their state. We did not realize until then that there was some state opportunity there. So what we did is we advocated, and this law is such that that it basically says that if there's a reasonable likelihood that a test, whether it's a lab test or a radiologic test, if there is a reasonable likelihood of malignancy, then the health system is required to delay that result by 72 hours. Now, there are some provisions there that if health system has no IT ability to do so, they can be excluded. But what I would ask is that all of us reach out to our health systems and to find out how they plan on doing this. So this is going to be great because, as we all know, not just incidental findings, but it's not uncommon that we actually see a good amount of cancer being diagnosed on when we're looking for on a CT for abdominal pain or even ultrasounds, MRIs. So this gives us that opportunity to
Mhm.
delay the result.
Question, that phrase reasonable likelihood, that's I know in the bill that phrase is in quotations. How is a physician going to be able to define that? Or could you also just have a blanket policy that we're not going to release for 72 hours? Do
Yeah,
you
I
know?
mean, my recommendation would be a blanket. And the reason why I say that is because of the high percentage of CTs, MRIs, and ultrasounds that do find malignancy, right? So, incidentally or as the cause of their pain, nausea,
Right.
vomiting. And so we do have data to support that. So, especially with CAT scan imaging.
Yeah, particularly if, I mean, if I'm a patient and I know of this law and I haven't gotten my results for 72 hours, I'm going to actually start to worry more that I haven't gotten them, right? Like what's wrong? So, well, hey, let's move on to the next one. This one's around restrictions on firearms in hospitals that provide mental health services. So, Amy, can you tell us a little bit about that?
Yes, happy to. So this is a bill that I think it dovetails nicely with the bills that we've passed in the past, in years past, that talk about making sure that healthcare workers are protected in the workplace. And so we passed a bill that required security in hospitals, and this is kind of the next step to that, which actually says that if you are an emergency department and you provide mental health services, which basically that is all emergency departments in Virginia, that you cannot carry firearms or other knives or other dangerous weapons in. And so this was a law that just took effect, and the governor actually signed it a ceremonial signing last week at down in Norfolk. And so this is a bill I think that will again continue to help ensure that the public is aware that you are not supposed to bring your firearms in. So if you have anything, if you are legally able to carry, you should just leave it in your car. Obviously, if you're not legally able to carry, you should not be bringing that into the emergency department. And it was surprising to me during testimony how many different types of weapons are brought in, and the number of them every year to hospital emergency departments was staggering. And
Wow.
so I really hope this will help keep people safe and help people, just be really much more on alert that you're not supposed to do this anymore and make
Wow.
that a law. So.
Have you seen this in practice, doctor?
Yeah, so I will say my hospital has metal detectors, and to Amy's point, it's surprising all the things that patients bring through. So most of the time unaware, right? They are unaware that they're carrying that, the knife on them. A lot of patients who have concealed carry. And so it does bring awareness, but hopefully, we'll get to a point where there are metal detectors, and that pick up on a lot of these weapons. And I will say the reason why this is also so important, it might not be that reasonable patient carrying that knife into the department. That's the worry. It's the um, patient who might be having a mental health crisis that ends up pulling the knife off of that other patient or that gun, and now it becomes a serious threat, right? So trying to avoid having any firearms in the department is best for all.
And continuing with you, Dr. Sequeira, Dr. Sequeira has been on a 10-year kind of journey to make small reforms along the way to Virginia's mental behavioral health system. And this is one of those other wins that we got this year on updates to how medical temporary detention orders are granted and some security requirements around that. So tell us a little bit about this bill.
Yeah. So right now, we have a good number of patients who are either intoxicated, they are altered, have altered mental status because head injury, liver dysfunction, all different reasons why they could be altered. Could even be a psychiatric reason. But if I'm worried that there's a medical problem going on, in the past, what has happened is I'm trying to get on the phone to obtain this medical TDO from the magistrate. And meanwhile, this patient is actively running away. And we've had cases where a patient has left the building, no one has secured that patient, and the patient has gotten, unfortunately, hit by a car or injured in some way. So the ask and the law now passed as of July 1st is that when a physician is petitioning for a medical TDO, then the facility is to secure that patient for up to 2 hours. And usually 2 hours we thought was a very reasonable amount of time because of the time it takes to petition and get that TDO officially signed.
Mhm. Great. Sounds like something that will improve the workplace for a lot of physicians and their teams.
Yes, most definitely. And I would also say, like, we should, in those cases where we're worried, even those patients who might be saying, a lot of our intoxicated patients, I think, are the big ones that have a head injury and we don't know whether or not they need a CAT scan. This is the opportunity to bridge that gap so
Mhm.
that we are able to do right by them.
Great. Amy, in this the world of AI slop that we're in right now, there's another bill that's going to help improve, add more transparency to medical coding, particularly on the payer side. So tell us a little bit about this bill.
Yeah, we passed a bill passed this year with that was led by the Medical Society and supported strongly by VASEP was a bill dealing with the sort of the larger world of downcoding, which is something that I think emergency physicians face every day in their
Yep.
practice. And this does a couple different things. One, it does deal with AI. It says that you cannot use AI solely to downcode. So there has to be a human involved in that process. It can't just be done solely by AI. It also cannot be based solely on CPT codes, so it has to have other information included in it before you can downcode. There has to be a clear explanation of why something was downcoded, and there has to be a clear appeals process, which I think is also really important. And finally, you're allowed to do these in batches, and so there is
Hmm.
it's not just like individual stuff now. So there's like if you want to appeal them, you can appeal them in batches, and so I think that should be helpful too for physicians. We know in this world where healthcare is getting more complicated every day, we are constantly fighting. It's sort of just a pop-up always of downcoding issues that are coming up. And so we're really hopeful that this will help be a step in that direction to help with physicians to appropriately get paid for the services they provide, right? And not make it so difficult administratively to have to fight against those. There's more to be done, I am sure, in this area, but we think this is a great first step.
Yeah, reimbursement, downcoding, it is an ongoing topic as it has been for years. So yeah.
And so
Decades.
this law is huge for us, right? In the
Hmm.
emergency medicine, physician, and APP world. And that's because we are seeing commercial payers paying, unfortunately, a little less because of downcoding. And when Amy talks about CPT codes, we're talking about final diagnosis, right? And so we saw this a little bit with DMAS a couple of years ago when we had the lawsuit related to final diagnosis. A patient coming in with chest pain, and while we put GERD as their final diagnosis, after, with their history of hypertension, they're 50 years old and got all the risk factors. We work them up, and then luckily it ends up being GERD. But they came in with that chest pain. It could have been a heart attack, and so we know why that's wrong. But this legislation kind of helps strengthen the ability for us to appeal and kind of push back against those final diagnosis
Great,
downcodes.
great. Sticking with you, there's another bill on petitioning for emergency custody and temporary detention orders, kind of a workforce expansion bill. Tell us a little about that.
So this is great. So, we know that our police officers are all busy, and especially the ones that are on active duty, right? We want them to provide safety in our communities as well as safety in our ER. So, what this law does is it allows retired police officers to now be able to petition as well as detain ECOs and TDOs. And so this, as you said, expands that workforce ability so that our active police officers can do what they need to do on the streets.
So help us understand when a retired officer might be involved in a situation like this.
Yeah, so frequently we have our patients who are under an ECO in the emergency department. And while a patient is under an ECO waiting for their TDO, they have to be detained by a police officer, right? And so it's not uncommon, right, that there's 3, 4 ECOs in our department. So that's one police officer essentially, with them. And so that's a lot of a workforce being taken
Hmm.
out from the police officers, team. So yeah, so having a retired officer is really valuable there.
Someone who can come out of retirement and just uh, be part of it. Yeah, great,
Yeah.
great, great. On the topic of workplace violence and workforce protections, Amy, there's a bit of an expansion to some of the work that hospitals are doing with data gathering and reporting. Tell us a bit about that.
Yes, happy to. So, this not this session, but the session before, we worked really closely with the Medical Society and our other specialty friends, and there was a law that was passed that required internal gathering of data dealing with hospital and workplace violence. And so what that meant was that hospitals had to have a system that collected all the same data. So we were getting the same data from all over the different hospital systems, which we had not had before. So one year they had to do that internal process. And then this year we have updated that. And now with the help and the work of BHHA and BASEP and MSV, that they are going to be very clear about what's going to be publicly reported now.
Mhm.
So this information that they would be gathering internally, now there will be a list of information that will be publicly
Public.
reported every year to VDH, and it'll be compiled, and there'll be a report. It won't be any, identifying information, so nothing, like no personally identifying information will be in there at all. It'll just be identified by people's job description, like job titles. So it could be like,
Hmm.
was it a nurse? Was it a PA? Was it a physician that
Got it.
experienced violence? And they're going to be doing it more in a regional way as opposed, so it's also not going to be hospital by hospital. So you won't be able to really kind of pinpoint and figure out who the people are. So we're working towards all this information to do a better job of knowing, because I think when we have the tools to know where is hospital violence happening and if it's happening in its
Hmm.
level of frequency, then people can have better tools to be able to respond
Yeah.
to it
It'd
within that
be,
hospital system. And it's also requiring reporting to other people in the hospital itself too. So like if there's an incident in the emergency department, it has to get reported through a system. So there is like a CMO that has to know, and it kind of gets reported
wow.
up the chain. Because right now sometimes it happens that there can be violence that happens in a different department and other departments never know about it at all.
Hmm.
So again, trying to have more transparency and data transparency within the hospital system, and then again without.
Yeah.
So though I'm sure this is something that'll be an ongoing process that we'll need to continue to amend and kind of tweak. But again, we went from the internal reporting process to now an external one, again, to do a better job. Transparency will help as well as getting this data so we can really do a better job of keeping our providers and physicians and nurses safer
Yeah.
in their workplace.
Be interesting to see what a year of this data looks like and really give us an illustration of workplace violence in the state. So,
Yeah.
um, and finally, we'll talk about a few others here, but I want to talk a bit about scope of practice this year. This is an issue that kind of pops up every year with one type of specialty or another. So, specific to physician assistants this year, Dr. Sakara, what did we see?
Yeah, so this year, kind of as expected, the PAs lobbied to practice independently after 3 years, similar to their NP colleagues. So while that did go through and while that is passed, we, as VASEP as well as MSV, were very integral and had a good amount of communication and how that would look. And I honestly, the PAs were very willing to work with us because just like us, they want to make sure that their training is standardized and that we are safely practicing independently.
Hmm.
So to that end, they will be able to practice independently as long as they are supervised by a physician within that specialty. So if you and you have to be, that physician has to be aware that this 3-year process is happening to gain independence, right? And so. And then I will also say that just like with our NP colleagues, Virginia ASAP has guidelines, or not really guidelines, what we think should be the bare minimum, i.e., the ACGME requirements to be a independent NP or an independent PA. And as you can see on our website, they are very much in line with what ACGME requires of a resident. Because as we all believe, right, it's the residency that makes you a great ER physician. It is not just medical school. So we want to make sure that they are trained in a similar way. I will also say that the Board of Medicine still has regulations that they will create. The PAs licensed independently will fall under the Board of Medicine, which is a little bit different than the way NPs are licensed and disciplined for that matter. So the Board of Medicine will be managing all the regulations relating to physician assistants, and so we will continue to be a part of that discussion as well.
Great, great. And we'll put a link to those requirements on the podcast show notes. And speaking of Board of Medicine, I think it's a good time to kind of take a little detour here and talk about some of the work that's been done to kind of reform the structure of the board, but also to help with some of these unfounded complaints that not only emergency physicians receive, but just the entire doctors of all shapes and colors. So tell us a little bit about this bill that came out this year. This was by led by VASEP, sponsored by the General Assembly's only physician legislator, Mark Downey. Amy, tell us a little bit about what this bill did.
Yeah, sure. This process sort of started about a year ago when VASEP went and has had a couple of meetings with the Department of Health Professions and the Board of Medicine to see what we can do to help kind of streamline that process and help them really just provide them with more information about sort of what it's like to be an emergency physician, right? It's especially important when you're talking about investigations and when people get complaints, so that the more that the staff knows kind of like what it's like to practice as an emergency physician, they can tell much more quickly whether or not a complaint is founded or unfounded, and
Hmm.
that sort of helps the process. And so one of the ways that sort of came out in those conversations was that having more specialties represented on the Board of Medicine would be important because especially we haven't had an emergency physician on there in a long time, and there is a restriction. The Board of Medicine was the only board under the Department of Health Professions that required a physician from every congressional district. So that meant the 11 physicians had to come from 11 congressional districts. So that really limited kind of who could be appointed. So what we did was we went ahead and changed the law this year and took out that congressional district requirement, which then makes it a little bit easier for different specialties to be appointed. So they don't have to be, we want to be able to ensure clearly that there is still geographic diversity, but we want to be able to also ensure that there is specialty diversity for people because there are a lot of specialties that are very different.
Yeah,
Pediatricians don't know working in an emergency department. Family doctors don't know what it's like to be a surgeon. So I think it's like just having as many specialties on the board will provide
hmm,
a diversity of experience. And they're the ones that the staff go to when they have complaints and they have any questions. So if they have a complaint and they're like, we're not sure whether or not this is a violation, they go to the board. So it really matters what types of
yeah,
physicians are
sure.
on the board to be able to provide that expertise. And so we're kind of working towards that. That'll take effect on July 1st. And so
Hmm.
moving forward, any board appointments will be able to have, I think what we hope is sort of a good geographic and specialty
And
diversity
specialty mix, yeah,
across
yeah,
the
sure,
Commonwealth.
sure.
That's right. That's
But
right.
the work doesn't end there. I know we've put
Nope.
together a complaint handbook, and we want to be clear, like we're talking about unfounded complaints. There are certainly the Board of Medicine certainly does have a role in regulating this, and there are
Of
valid
course.
complaints out there. But those that are unsubstantiated, those that could be solved with a phone call, that's really what we're talking about. So tell us a little bit about some of the work that's kind of still taking place behind the scenes, and what we're trying to do there with the board's process for investigations.
Sure, it's sort of what I talked about before. It's trying to figure out how we can provide any help or expertise to them for knowing, even for example, like there was a complaint that happened that dealt with a mental health patient, and the an emergency physician was named in that, even though the issue was dealing with inpatient stuff. That should have been clearly, I think, just discounted right from the start. So I think again, helping to educate the staff more on what emergency physician practice looks like, to help them know kind of those pieces, I think is really important. We're also looking at different ways on the website to make it more clear for people who are kind of even coming there to make a complaint, what that looks like for them, and the fact that they know that this is a very serious thing that they're doing. This isn't just a Yelp review. If they're upset with the practice that they've had, whether it's emergency
Right.
physician or a surgeon, that they really know that this is a huge step to take, because this is going to be an investigation on someone's
Yeah,
license, which can affect their ability to practice. And so
sure.
I'm just trying to make it, I think, a little bit more serious for people who are reading it, because I do think there has been an increase in complaints, and it's sort of like an increase in complaints we've seen just in everything,
Yeah,
in the world, right? I mean, people complain about airlines, and people are
yeah.
complaining about teachers and schools. And
But
so I think there's been just an uptick in general in our society in complaints. But obviously, when you're talking about a complaint, you really need to know that if it is a serious complaint, we want the Board of Medicine to spend the time on the doctors who really need to be investigated, who are
yeah,
doing really terrible things to patients. We don't want them to have to spend their time on things that are not substantiated. So just I think we're trying to find all those places where we can make it a little bit more clear for people who are applying with a complaint, and also for people who are receiving those complaints on the back end too.
sure.
So
Yeah.
a
I,
work in
I
progress for sure.
I like that. The Board of Medicine is not Yelp.
Yeah.
Well, hey, in the final minutes here, I want to open it up to both of you to talk through any of the other changes coming on the first and some of those other bills that maybe didn't make the headlines, but are nonetheless important for our emergency physicians to know about.
Yeah, I mean, I can talk about two, just one-liners, I guess. So,
Yeah.
so we are all aware of the red flag law. In the past, police officers were the ones who were able to petition that. But now, we as physicians are able to petition. It's officially called the substantial risk order. And so, again, if you have a patient or someone who has weapons at home that you are concerned is a substantial harm to others or themselves, can petition the magistrate about having those removed. So that is one law that is coming to be. And then another one relates to the PMP and now having a list of when methadone was dispensed recently. So this is a great help to that person on the ground, right? Physician who we have to always double check. What is the dose? When was it dispensed? And, to rectify that it is the truth. And so this will now allow us to save a lot of time in doing that investigation because it'll be right there on the PMP.
Cool. Amy, any other bills you want to discuss?
Just one more. I think there's one more that's important for physicians. There will now be a new requirement that Medicaid will pay for telemedicine provider to provider consultations, which is important. I think that needed to be clarified. I think there's a whole lot more consultations that happen over telemedicine, and now the Medicaid program will have to pay for the provider's time on both ends. And so I think that's an important piece, just a clarification, not a big bill, but one that hopefully will have some impact, and I think will again generate and help relationships and that communication between providers when they're talking.
Great. Well, with that, we appreciate both you for being here. Appreciate everyone for listening. Details on all these bills can be found on the VASEP website under our news page. We hope you enjoyed today and learned a little bit about how your practice will change on July 1st. Thanks for joining us, and we'll see you on the next show.